We would like to start the part 2, the Independent Investigation Commission on the Japanese government response to COVID-19 API ICJC. We would like to start the keynote speech followed by panel discussion. I would like to introduce the next speaker, Shiozaki Akihisa, partner, Nagashima, Ohno, and Tsunematsu, co-chief examiner of the working group of API ICJC. The speech is entitled Lessons Learned and Recommendations from the ICJC Report and Japan's Response to the Third Wave of COVID-19 Pandemic. Mr. Shiozaki, the floor is yours.
Thank you. Good afternoon, ladies and gentlemen. For COVID-19, the Independent Investigation Commission, the Japanese government's response to COVID-19. My name is Shiozaki. I served as a co-chief examiner. Even though this is the weekend, we see such a large attendance through the web on virtual basis. I'm delighted to see such a large audience. I myself, 10 years ago, would have been involved with the Independent Investigation Commission on the Fukushima nuclear head accident, together with Professor Suzuki. I have been listening carefully to the presentations as well as the questions raised from the audience, and I was recalling my fond memories back 10 years ago and what has happened during the 10 years. I believe there seems to be some common thread running and common issues still remaining, which will also be applicable to COVID-19 situation as well. I will be giving you the outline to explain the report on best practices and lessons learned of the Independent Investigation Commission, and then we will have the panel discussion, what has been the lessons learned and what has been the issues we have found. So please move to the next slide. The Independent Investigation Commission on the Japanese government's response to COVID-19, the very first wave of the pandemic, up until June and July last year, and we have published a report in October. Various countries have gone through the testing and had the mandatory lockdown measures been undertaken, whereas for Japan, we had an original response. The number of tests were not that many. And for the behavioral change, the government has made a request for cooperation by the Japanese people. The so-called soft lockdown was the measure undertaken. For such response of the government, we have made assessment. We have quoted from one staff of the Kante, the Prime Minister's office. The process was sloppy, but the results turned out okay. What it means is that in the first wave of the pandemic, as a consequence, the number of deaths and number of the infected people were smaller in number as compared to the other countries. But could the success be reproducible when we meet with second wave and third wave? Will the same measures be effective or not? That is not guaranteed. Thus, we needed to examine thoroughly what actually happened. Now, look at what has happened ever since then. So if you look at the slide and this chart, unfortunately, as you can see, in the second wave and third wave, far beyond the first wave in terms of the spread of infection. In the phase when the infection was expanding and spreading, the government has asked for a behavioral change, the telework, as well as to refrain from going outside and not hold parties or eat out with your friends and families in the restaurants. But we were not able to contain the increase in number of the infections. And the second, the declaration of state of emergency, it had to be issued on the February the 7th. Why have we met with this result? Couldn't we have prevented this to happen? So we should look back with the lessons learned through the first wave. As to the content of our evaluation, as we see many lessons learned, there are three themes mainly which we believe have been linked to the third wave. Firstly, poor preparedness narrowed policy options. For the COVID-19, when it was first seen in Japan back in January last year, the number of the testing of the PCR was only about 300 per day nationwide. And pandemic, which could spread to the whole nation, the number of testing was too few in number. So what to do with this? The preparedness was in question. Not only the number of tests, but what is called infection surveillance. Who was infected where? And what are the numbers of infections? In terms of information collection function, the public health centers will collect information using facsimile and provide information on handwritten basis to the headquarters. There is time lag, it's too time-consuming, and too many people had to be involved. So it was highly problematic. And facial masks were in dire shortage. I'm sure many of you have gone through the difficulty to try to buy a mask for yourselves. So how to prepare yourself? It was not that Japan did not know how to do that. When there was we have seen it back in 2009, when the novel, the influenza infection has been seen. Why were the lessons not learned? And the Minister of Health and Welfare staff had said, lessons were forgotten as soon as the danger was gone. In other words, when the new influenza have landed, and whenever the pandemic happened overseas, every time there will be heightened interest, and people think that we need to be prepared, and there will be budget allocated from the government. But the next year, and then the following year, people start to think that there is no urgency. We don't have to do it now. Was a kind of thinking, especially for the new type of influenza. It did not spread that much in Japan at the time. So when we speak of the pandemic, people thought that it was manageable, that we were trapped with our own success. And that has led to no budget being allocated and no preparedness being seen. Within ourselves, what is called as tail risk. The possibility may be smaller, but the impact may be greater. We had to have some separate budgeting the process, or have some reserve fund to be made available, and have the healthcare the workers to be always retained for emergency purposes. And how about preparedness in terms of hospital beds? And the preparation may have been lacking and in shortage. We have found all of these things. So how should we define the preparedness? How should we prepare ourselves? This is the kind of discussion I would like to have with our panelists.
2番目のテーマが
The second theme, conflict between safety and reassurance. The first half, during the Fukushima panel, Professor Suzuki talked about you shouldn't pursue small-scale sense of comfort at the risk of larger-scale safety. Here, for COVID-19, the safety and reassurance don't always meet with each other, and there are some vacillation in terms of policy. For instance, declaration of full closure of schools. Prime Minister Abe did that February last year. Scientifically or epidemiologically, perhaps that kind of measure was not necessary. Experts voiced such opinions, but in terms of politics, as the infection was spreading, to be prepared for everything, and then they had to address the anxiety of people. So they decided to close the school nationwide. Also, lifting on the state of emergency declaration, science and experts and epidemiologists Their opinion was that the situation was not ripe for lifting that state of emergency. But on the part of the government, there is anxiety and dissatisfaction on the part of the Japanese people. Perhaps they have reached the kind of a saturation limit between politicians and experts on the lifting of the declaration. About the timing, there were negotiations. And what was more symbolic was that PCR tests, to expand the capacity of PCR testing. On the part of the government, people have anxiety because they cannot take tests, so doubling the capacity. That was what was initiated. On the other hand, MHLW, the Ministry of Health, regarding PCR tests, even without increasing PCR tests, it will be okay. A different logic was explained by MHLW on certain occasions. So this is one comment or message. Since PCR testing does not have 100% sensitivity and specificity, there are problems with wide-scope testing. That was the message conveyed from the ministry, MHLW. This is not necessarily wrong, but do you want to stand on the safety side or stand on the reassurance? See, this message can be interpreted in different ways. Third wave, in addressing the third wave, there was something called Go-To campaign, tourism promotion campaign. From the safety perspective, what do you think? And there were a lot of discussions going on about between the safety and reassurance, which should take precedence under which circumstances. This is a very difficult theme. We are still faced with this question. Last but not least, this is number 3. Good risk communication and weak crisis communication. In responding to the first wave, risk communication about infection disease, risk of infectious diseases, how to convey that to the people of Japan. And there are some good creative ideas. 3 C's, that's the symbolic. To avoid 3 C's, by avoiding 3 C's, even you don't do the lockdown, while you are engaged in, to a certain extent, normal behavior, perhaps one can prevent infectious disease. A difficult balance can be stricken using these 3 C's. This message was embedded to the people, and this is something we can be proud of to the world as a creative idea we had with experts and MHLW, the government. Their teamwork actually functioned pretty well in certain occasions. On the other hand, about government COVID-19 responses, what about the people's trust? Internationally speaking, despite the moderate success when it comes to government information, government responses, they are not really trustworthy. People are not satisfied. Dr. Omi of the experts group, when I interviewed Dr. Omi, this is what he said. On the part of the government, specific questions were asked by the government, but from our perspective, yes, they are important, but we received a lot of specific questions. While these questions are important, we had greater concern towards the lack of the big picture. How infectious diseases are difficult, dangerous. That's the narrow scale risk communication. But not just limited to that. How to resolve this matter? What is the priority of the government? What is the roadmap? That overall message in the first wave was not communicated well enough to the people. Why? As a risk communication issue, we raised this issue as well. In responding to the third wave, risk communication, crisis communication, how to do this? They continue to be one important thing. We would like to have a discussion later in the panel. Lastly, in our report, as a concluding remark, this is what we said, a message. Crises never repeat in the same manner. but they always return in a different form. We share responsibility to learn how to learn. When we wrote this, we didn't know that the third wave would hit us in this way. But when one way or another, it might hit us. And unfortunately, that concern has been manifested as the third wave. What we have learned from the first wave, in responding to the third wave, what do we have to learn? On extension, Fukushima, from the experience 10 years ago, what have we learned? What needs to be continued and passed on to the future? We would like to address those things. Thank you so much for your kind attention.
Thank you very much. Next, we would like to move on to the panel discussion. Second, declaration of state of emergency. How has Japan been responding to the crisis? The moderator will be Mr. Akihisa Shiozaki, and the panelists are Advisor, former Chief Medical and Global Health Officer of the MHLW, Dr. Yasuhiro Suzuki, Deputy Co-Chief Examiner Working Group of Investigation Committee for COVID-19, and Editor-in-Chief of M.3Com, and Professor Harutaka Takenaka of the National Graduate Institute for Policy Studies. I would like to hand it over to Mr. Shiozaki, who will be moderating this session. Thank you very much. We have a very distinguished panelists. We would like to look back on a variety of topics. This response to COVID-19, we're in the midst of the third wave. So from the first wave, what have we learned or what have we not learned? And how should we think about the third wave? These are the things that we would like to discuss in this session. So starting with Mr. Takenaka, Professor Takenaka, this COVID crisis, you have written this book, The Politics of COVID Crisis. There are many of us in ICJC, but Professor Takenoko, you have single-handedly put together this report, which is a very intensive, dense book in terms of content, and I have learned a great deal from this book myself. And Professor Takenaka, in the first wave, you have written a book on the response of the first wave, conducted investigations and reviews, and Japan, unfortunately, were in the third wave and was forced to issue the second declaration of the state of emergency. Now, constraints and inundation of the medical system, from your perspective, what is in the background of the medical system being inundated? Why were we not prepared? What is your view on this? This is Takenaka, and thank you very much for this opportunity. And thank you very much for introducing my book. That was very kind of you. Mr. Shiozaki, I'm appreciative. Now, medical system, why was it inundated? There are many discussions underway, but in the case of Japan, there are structural issues. 70% of the hospitals are private hospitals, and there are many small and medium-sized hospitals. So it's very difficult to clearly segregate the way that people move, and at middle and small-sized medical institutions, it's very difficult to separate out the patients. And beds with more than 300 beds do accept COVID-19 patients. This is backed by data. But there's another thing. There are moral issues, unfortunately. Moral issues? The morals of medical practitioners, healthcare workers, that is. When there is a COVID incident, people don't like it because they think that they would become very busy. But once you receive COVID patients, you need more healthcare professionals, so they will not be able to attend other patients. So this is going to be a business issues at the private sector medical hospitals. This is a fact. So this is a business management decision. It's difficult. So what can the public sector do? There may have been some things that the public sector may have been able to do. The Tokyo metropolitan government may be a problem. MHLW has been asking for establishment of dedicated hospitals. Osaka started this on their own initiative, and in response to that, MHLW issued an order. Early on, they have set up dedicated hospitals for COVID-19, but not in Tokyo. When you have a dedicated hospital, it will be more efficient in terms of examining patients, so the capacity can be raised. But for some reason, it's only in January that the Hiro, Ezbara, and Toshima hospitals were made designated hospitals. So the capacity has been raised from 3,000 to 5,000. So Tokyo metropolitan government has a responsibility to explain why. And many people do not discuss this. I would like to ask Dr. Suzuki as well. National Hospital Organization, why was it not mobilized more? Because the government has medical resources. If it is only central hospital and SDF hospitals, that will be too unfortunate if that is the only resource that they can use. Professor Takenaka, I think you have your line has frozen. So let us take this opportunity and turning to Suzuki-san. As was asked by Professor Takenaka, in terms of developing beds at medical institutions, there is the responsibility of governors, but at the central government, maybe National Hospital Organization's capacity could be freed up. That was a point made. So in the third wave, when you have inundation of hospital beds, Dr. Suzuki, until the 7th of August, you were the former Chief Medical and Global Health Officer. So what is your view on this? And looking back, do you think you could have done better in a different way? Please.
Thank you. Thank you for the introduction. Before going into the question of the National Hospital Organization, let me talk about the hospital beds. Per population, there are so many hospital beds. Why is that we are facing the dire shortage? In Japan, we have so many beds, so that medical staff is actually in a shortage. So whatever an emergency happens, the number of staff is too small. Different from some of the European or American companies, not for a number of beds per population. That is not the problem. The problem is to do with the medical staff, the healthcare staff. For the National Hospital Organization, I may be criticizing the leadership of the organization. It has become an independent or incorporated agency rather than a pure the government-related agency, even though it comes under the command and control of Minister of Health, Labor and the Welfare, as compared to the past when it was purely a national hospital. Perhaps the effectiveness may have been degraded somewhat. So as Mr. Shiozaki has mentioned, what to be improved and amended going forward to the National Hospital Organization or to some of the public hospitals, we need to position them as the hospitals to be responsible for certain emergency cases.
So for the National Hospital Organization and MHLW, specific instructions can be given by the MHLW. Yes, that's written. So the authority to utilize such exercise authority, including preparedness, you need to come up with certain assumptions. I think that's the case. Thank you. Next, Hashimoto-san. Ms. Hashimoto. Among the three, in the last part, about risk communication. Before getting into that, may I comment on what's been discussed? Yes, about the tight supply of hospital beds. I think there's some misunderstanding when I look at the current situation. People often talk about this. In Japan, the infection cases is small. And there are a lot of hospital beds. How come there is so much trouble in finding hospital beds? Yes, that's right. I think at the same time last year, Italy, New York, on the corridors of hospitals, there are so many patients, and also outside tents, there were so many patients. So Europe and the United States, they didn't have any problems about the supply of hospital beds. I think there was an issue, there was a problem. So first, one needs to acknowledge that tight supply situation. Suzuki-san said before, fewer cases. That's right. That's right. In OECD, there's health data. 2019, for 10 million number of doctors, 2.4 in Japan. OECD average is 3.5 persons, 3.5 doctors. That means, yes, the concentration is not so high. And hospital beds, there are a lot of hospital beds, but the hospital beds definition is not uniform internationally. In Japanese, the general hospital beds, and also for recuperation, and there are various types. And generally speaking, yes, it's high for acute treatment. Relatively high number of the hospital beds available to address those people who have acute situation. If I may just add one more thing, February 9th, Tokyo Medical Association, Tokyo is highest number of cases. And in terms of hospitals, 64.9%, those are the private hospitals. And in scale-wise, it's small. If you look at the ratio of patients, 38.4%. So that's handled by the private hospitals. I would like you to first acknowledge that, understand that situation. Having said that, MHLW, Suzuki-san, I think it was June, you were still in your capacity official. And then there was a plan to lower the number of cases. Each prefecture did that. Later, we will be discussing, I think, the governors. There was a plan. Plan was devised, but when, who will implement it, where, those specifics are, depending on prefecture, they didn't address that. It was really a kind of a pie in the air. And then, depending on the infection situation, if they were able to address this, I think this tight supply situation could have been avoided. But there were certainly problems in terms of execution. This should be a homework for the future. Thank you. So Hashimoto-san, compared with overseas, we have relatively more hospital beds, but that assumption is actually wrong. We don't have so many hospital beds to begin with, and the number is comparable. And in terms of the tight supply situation, yes, we are faced with a difficult situation.
And up until the planning, it was done until last year, but they were not able to implement that properly, or there was no follow-up process to check on this. So, as a consequence, the number of beds have not increased at all. That is what we have found. In part one, Mr. Suzuki was saying about the homework assignment style of regulation. So they have indicated the target, but that was not actually done. So, Mr. Takenaka, you would have actually put an oil into the fire, so to speak, for this hospital bed issue. And Hashimoto-san also touched upon the number of hospital beds and also a shortage of healthcare the workers. And for the National Hospital Organization, they do have authority. So what to do going forward? There was an issue shared by everybody. So may I go back to Hashimoto-san on risk communication? At this time, there were some successful examples where experts have been quite active. Of course, there are many arguments. During the first wave, from my own point of view, there was good cooperation and collaboration seen. As compared to what happened at Fukushima accident 10 years ago, the expert team, I'm sure Mr. Suzuki has been instrumental, at the very early stage, they have been able to, not as an individual, but as a team, provide advice to the government, and that was good. But on the other hand, the experts and the government, there have been miscommunication, and the difference in the positions that was seen in not only in the first wave, but second and third waves. And what to think about the Go To Travel campaign between the experts and the government, the people, there has been difference in views. So when there are disagreements between the government and the experts, what to do with that? Do you think that this is something healthy and sound and this should be the proper way to go? Or rather, there are challenges that you need to build a better relationship. What would you think of this?
That's a very difficult but important issue. You need to deal with the partner on a merit basis, depending on the case and the issue. Now, the government's response to COVID-19 and the experts committee, their relationship has changed over time. So let us take a look back, especially with respect to the first wave. Experts, they themselves were using this phrase that they were forward-leaning. They had to be. And as a result, in terms of cases and deaths per population, we were able to reduce it and keep it low. They had to be forward-leaning. There are mostly two reasons why. First is, I'm just, as a national citizen, COVID-19 was something that is unknown. So people have this sense of fear for something they don't know. So what is the risk of this infectious disease? It had to be assessed. Right now, we're talking about the balance between the economy and counter-infection measures. But you need to first understand the risk before you can take countermeasures. So that is why experts were forward-leaning. So this is the reason, the first reason why. Now, the fatality rate and infectious level, we know more about the enemy now, and that is why some people have become relaxed. But we can now take the right balance between counter-infection measures and the economy. Initially, we didn't know how to balance the two. So then, you need to rely on experts in terms of prevention of infection. And this relationship between experts and the government, depending on the position and the level of sense of crisis, there were differences between the two parties. Now, experts on infectious diseases, they have knowledge, expertise. It's not just them, but they are in a position to be able to get information from the overseas. They know the level of sense of crisis, but on the government side, they get information as secondary information through these experts. Then what is the level of the risk of this infectious disease? There have been some differences in the level of sense of crisis. And experts think about the disease, and the government thinks about the balance between the disease and the economy and the society. So experts had to be forward-leaning initially. They needed to emphasize the importance of taking measures against infection. So that is what happened in the first wave. But in June, I think it was on the 24th of June, experts issued a report, a graduate thesis. Because we know the enemy more, this virus more, the balance between the politicians and the experts has changed. The government started to step on the gas, acceleration pedal more to drive the economy. So the balance started to change from then. On the other hand, the position of the politicians started to change, and the experts have started to sense that. So recently, they are not able to say what they are supposed to say. That is what I feel. What do you mean? Then let us hand this over to Dr. Suzuki from overseas. We have a question from Kazuto-san.
Now, there are things that need to be considered by the government, societal request and demand, and the experts on the other hand, how to coordinate between them. Dr. Suzuki, during the first wave, you were at the top position, the Chief Medical and Global Health Officer at the Ministry of Health, Labor and Welfare. So, how to utilize the experts' the view to be reflected on policy making. What they say may be different from what the politicians want to hear. So there are risks involved. But how to reflect experts' views in a skillful manner into the policy making? Were there anything that you have devised in your way to try to skillfully utilize them? There is the one axis, the defense for the infection, and also how to have economic development, and also the information as ingredients, and also the decision to be made, including those ingredients. So as was suggested earlier, it was a quite healthy and sound arguments and debate, because politicians and experts have different perspectives, so disagreements are something healthy. It is often taken for granted, but transparency is the important thing. And when decision is taken, you need to explain the process of the decision making to the general public. For the second axis, defending the infection and have the economy to grow, I believe no country in the world have a good answer to this. You need the vaccination and treatment. To what degree are you successful on these? It would depend upon that. And what about the bankruptcy? And what about the suicides happening in society and economy? Everything will depend upon those factors. But in any case, we are living in uncertainty. We need to make decisions against such uncertain times. And you need to make clear what decision was taken, why. And if necessary, you need to trace back the process and try to make better decision next time by narrowing the error.
Crisis has many different aspects, so you really cannot just find one. So policy making basis and the process, you have accountability for this. So the accountability becomes very important to be able to explain why such decisions have been taken. The viewers, you will be able to send in your questions through the Q&A icon. We will be taking up those questions. Next, turning to Dr. Suzuki once again. COVID response. Initially, we started with Diamond Princess coming to our shores. You have been looking at the situation. You have been giving instructions from the very initial stage. I am sure that you have had many, many difficulties. The first wave, when Diamond Princess came and when you conducted tests, 11 out of 30 was the positive rate. That was such a shock from then until today, looking back. Back then, what was the most difficult point as you faced the problem? And in responding to the first wave, we're in wave 3. Is there anything that you didn't expect or anticipate? This Diamond Princess, I think that was a turning point, because until then, it wasn't clear whether there's going to be people-to-people infection, and basically people thought that this was a disease that was emerging in China. But as this cruise ship came to Japan, It was an eye-opener. It was not somebody else's problem. This is our problem. It's not just at government level, but people have started to have that awareness. Looking back, this was entirely out of our expectation. And where we thought we did rather well is, as Mr. Shiozaki said, we conducted a survey to find out where people contracted the disease. We conducted that survey at bars, and we were able to find out how people get infected. We were quite early in doing that around the world compared to other countries around the world. So in terms of defense against infection, that was very important in terms of influencing people's behavior. We found out that people, when they are in close contact, you infect it. And once we know that elderly people tended to contract the disease and they have severe symptoms, we started to ban meeting people in nursing care homes. 80% in Canada of deaths are people in long-term facilities because well, of course, there are positives and negatives in banning people being able to meet those senior citizens in long-term care homes. But on the other side, elderly care, we were able to do well. But when it comes to younger people don't get seriously ill, and they also don't listen to the instructions of the government. So when you think about the third wave, young people spread infection, and now it has spread wider into the society. So how do we ask them to change their behavior? When you change your behavior, you can attend an event, or you can stay in a restaurant for longer hours, or if you get vaccinated, you stand to benefit. I think you need to package this with certain incentives. That will be important. Another thing, this disease, unlike seasonal flu, it's the incubation period where you're most infectious. In terms of seasonal flu, if you don't get close to people who are coughing, you don't contract it. But now we have thermometers at the entrance of the restaurant. When you can stop infection if it is a seasonal flu, but right now you infect others even if you don't run a fever. So when you have such a pandemic, what kind of preventive measures can you take? How do you ask young people to change their behavior? How do we send a message? That will become very important.
As Dr. Suzuki has just said, the asymptomatic patients tend to also infect others. That is a salient feature of the COVID-19. When you look at the Infectious Disease Act, you are able to take countermeasures where there is a questionable symptoms. So, when symptoms occur, that seems to be the premise. But it may be true not only for this time, but the next pandemic, there could be many asymptomatic patients. So as the virus evolves, we need to change our assumptions, perhaps. Mr. Takenaka, what Dr. Suzuki has suggested, what should be the message to the younger people, as younger people will be increasingly infected? That is what is different from the first wave. And as Mr. Takenaka, you have mentioned earlier, and you have mentioned in the book, as for the actual leadership for the infectious disease control, it should not be the Prime Minister, but the mayors and governors of the local governments, and perhaps on a public health center to public health center the basis. So asking for behavioral change for the younger generation, and to have better preparedness for the medical institutions. What about the governance gap between the national and the local governments? What was the impact of that? The authorities that have been divided into three different institutions, the national government and local governments. And in case of Tokyo Metropolitan Government, you have the Metropolitan Government as well as ward government. And in case of Kanagawa Prefecture, there are also the ordinance-based cities having a certain degree of independence as well. Of course, the governors can give the certain instructions, but if you don't have the vaccines or if you don't have the treatment drugs, what you need to do is stop the infection to spread. But the responsibility rests with public health centers. As Dr. Suzuki has mentioned, what to do with the behavioral change to be suggested to the younger people. I believe the national government needs to provide a message. But there are other things that the national government tried to do. Dr. Suzuki did not mention. But where the infection was spreading, as Dr. Nishiura has said, the entertainment area, night entertainment area, where there are bars and the pubs with the hostesses involved and so forth. From the end of March, that was suggested. So the countermeasures had to be taken. But for Shinjuku ward, the mayor has done well. And from the early June, for all the employees in the night entertainment area, bars and pubs, he has asked those employees to go through the testing. So there have been massive testing being done. And then Toshima ward followed suit, and the Ikebukuro ward also followed suit. And Minister Nishimura and Governor Koike said that this is something good. So that should be spread on a nationwide basis. And there has been 2 times a press conference. Prime Minister does not have this authority to conduct the test. And the governors do not have the authority to give order. It would depend upon the municipalities and wards, the mayors. The mayor of Kumagai City has done well, and City of Yokohama also did this. But then there has been a negative reaction from the restaurants and shops. But for Tokyo, what about the other wards? My feeling is that the other wards, other than those 3 wards that I have mentioned, did not do what they needed to do. So there were things and countermeasures that could have been undertaken, but it was not done. But what about the public health center? We cannot blame the public health center because there were too many infected patients. So the public health center were too busy. And on top of that, if they are to conduct massive PCR testing, was too much of a burden because ward is a small administration unit. To ask for the authority for the testing to such a unit would be too burdensome, especially the 23 wards in Tokyo, each ward that has responsibility for each ward's public health center. That is too difficult. Tokyo Metropolitan Government needs to have a system whereby the Metropolitan Government can give instructions to the public health center. Unless we have this command and control system in place, I don't think we will be able to deal with the next pandemic. The governor of Wakayama has done quite successfully, had been able to stop the infection. But the government, the Wakayama, the government, they may be angry. But putting aside the Wakayama city, but all the other public health centers come under the governor. So that is the difference. For Tokyo Metropolitan Governor, cannot give instructions to the public health centers belonging to the ward government. There is independence for the ward governments. We need to be mindful of that. Without this knowledge, I don't think we will have effective the system to counter the pandemic.
The Tokyo infection cases, that's a major factor. So being prepared for the future in the special zone, the authority to instruct public health centers in the case of pandemic emergency, it should be delegated to the governor of Tokyo. Perhaps such legal change might be necessary, or the central government to manage public health centers, or local governments manage public health centers, but directly managed public health centers perhaps can be prepared in metropolitan areas. Those public health officials, they have to be nurses. So normally, as part of the national health National Hospitals Association, but in the case of emergency, perhaps certain building can be prepared. Someone talked about the reservists. So reservist type of operation, because we are talking about crisis management, just like SDF, we are talking about emergency. Pandemic is emergent contingency. So, but the allocation of people in case of contingency, we have to address that issue. Also, in relation to local governments, another question. In our report, the declaration of emergency status was declared in the first wave. About 1 week before, Governor Tokyo mentioned if nothing is done, there might be lockdown. We may have to do lockdown in response. On the part of the central government, people might panic. And then there was a delay of declaration of the status of emergency. I had a chance to talk to Governor Koike, and Governor Koike said, no, I just repeated the words that had already been used in the experts meeting. Perhaps maybe I have more communicative power. Maybe that's why it hit the headline. The second declaration of the status of emergency, Governor Koike of Tokyo and the neighboring prefectures' governors made a request to the national government, and then government responded. As we look at what's been reported, not just about addressing infectious disease, more like a political maneuvering. When you look at those TV news programs, sometimes they sort of insinuate that kind of political insinuations. Are we being sort of manipulated, or the governance between the central government and the local government, political factors are inevitable? Is there always room for political influence? If there's such influence, how can we manage them? What do you think?
Of course, Governor of Tokyo or governors of local governments and the central government, Minister of Health, if they are on good terms, they have smooth consultation, be able to come up with good countermeasures. But that may not have been the situation. But in the first wave, because of the impact of the term lockdown, the declaration of state of emergency was delayed. But that is a theory that came out afterwards. So the delay in the issuance of declaration of state of emergency, I think this could just be an excuse, the government making an excuse that they were late because of the term that was used by the governor. And in the first wave, Osaka governor was also asking for the early declaration. And that urged the central government to make a move. So in terms of countermeasures against the infection, that was meaningful. Now, the third wave, the second declaration, things were more complex. Governor Koike said that asking establishments to shorten hours, they were shortening to 2200, but the government was asking to reduce this to 8 p.m., but Governor of Tokyo said that that's not going to be impactful. So Governor of Tokyo didn't listen to what the central government asked. But Go-To Travel campaign is more complex. If the government didn't do Go-To Travel, and if they had shifted to shortening business hours, and if the governor didn't listen to that, what the government is saying may be justified. But the central government said that they would continue with Go-To Travel campaign, except Hokkaido. So even in December 11th, Prime Minister was saying that people are blaming things on Go-To Travel campaign. So when the central government and local governments are not moving in lockstep, when local governments didn't listen to the central government's request to shorten business hours to 8 p.m., that argument may have been justified when the central government was still continuing on with the Go-To Travel campaign. It's very complex. So even if there was some political agenda, if the central government has already decided on a position, then that wouldn't have been a problem. they could have exercised more influence on governors.
In relation to this discussion, Ms. Hashimoto, I have a question for you. Internationally speaking, in terms of measures against infectious disease, both in the number of cases and the number of deaths, we are so-so okay. Even in the third wave, I think that's the result. Generally speaking, having said that, here in Japan, you don't get to hear such opinions. The government measures, if you look at the approval rate, evaluation by people, compared with foreign countries, approval rating is low, evaluation is also low. So the people of Japan, people's support of the government is not really spreading. We saw the same situation with regard to Fukushima accident. So communication issues, what are the reasons for this communication problem? What can be changed? Any input? Generally speaking, not just limited to COVID measures, are you happy? What do you think of Japan? People tend to be rather pessimistic as a general tendency, not just limited to measures against COVID. More recently, as you rightly said, the approval rate of the government is not really high. To give you one example, as Dr. Takenaka mentioned, go to travel, tourism promotion. I mean, you are stepping on both brakes and accelerators. What's really the policy of the government? People cannot see that. If you're not an expert in infectious disease, why are you stepping on the accelerators and brakes? They say that Minister Nishimura said that we win or lose 3 weeks on this November 25th. But people have distrust because there is discrepancy in the policies, what they say and what they do. And more recently, for very ordinary people's feelings. Finally, that go to travel was discontinued. I think that was December 14th. The announcement was made by the national government. And then there was this person who was enjoying steak with a group. You might call it just a small matter, but this really you really have to put your house in order. You are asking people, don't eat out, and then don't dine out. But some people are enjoying restaurants, and then I think that actually caused a sense of distrust among the people of Japan. About the communication issue, we may be discussing this later. There's increasing interest in vaccine. Of course, there's a supply issue and cannot be resolved inside Japan alone, and there's also the adverse effect. Communication must be done very meticulously, otherwise, first wave, PCR second, and the shortage of beds, and emergency declaration. And should there be another failure in vaccination, it might invite a bigger problem. I'm concerned.
Now that you have alluded to vaccines, Dr. Suzuki, vaccines around the world, there is competition to get hold of vaccines. Your national interest is at stake. Each country is trying to get hold of vaccines for their populations. And Japan, at a relatively early stage with Pfizer and AstraZeneca, a certain level of volume that could comfort the citizens, that such an announcement was made so that people were reassured. So we did rather well early on. But I'm sure you had a lot of difficulty. So what was the strategy in trying to make a move to get hold of vaccines? And once you got hold of vaccines, but in terms of administering vaccinations, Japan is late. For example, Israel is so advanced, and China also. Now here in Japan, we're cautious to make sure that it's safe. We have been following that process to ensure safety. So safety and sense of security, these are confronting each other, where there's a clash between the two. To what extent are we going to make sure there's safety? And at a certain point of time, we have to make a decision. And how do we address people's queries about their sense of security and comfort? What are the challenges? What are the difficulties that you see in vaccinations? First, there are two facts that we first have to understand. Until 1970s, Japan was a big vaccination nation, but as we have smaller numbers of children and we have less infections, when there are more adverse effects, many litigations, vaccinations waned. But in the U.S., unlike the U.S., we weren't hit by SARS or MERS. There was no consensus to step up vaccinations here in Japan. And it's not the Japan first principle, but around the world. When you produce vaccines in your country, I don't think people in power would not be able to make the choice of exporting those vaccines when there's not enough for one's national citizens. So a certain amount of vaccines must be produced internally. We have to have that capacity to produce a certain amount of vaccines internally. Positives and negatives. On the positive side, we sped up. When risk and cost was high, we asked vaccine companies to give us vaccines. So after R&D, production facility would be built, but that was done in parallel. When R&D was conducted, production facilities were set up and subsidies were given by the central government. So R&D was to be accelerated to get through approval. So there is a larger probability of having adverse effects, but that responsibility should not be placed on the industry fully. Of course, if there is defect or ill will, that's a separate matter, but the other risk would be borne by the government. That is how we ask the industry to come in. So these are the two things that we should continue to do in the next round too. But Mr. Shiozaki, you talked about the delay in administering vaccinations. This is a difficult issue. Why it's late? It's simple. In the initial phase, negotiations could be done quickly, but in the West, after clinical trials were completed, once again, we needed to check safety by conducting clinical trials in Japan. So that was a factor in delaying by 2 to 3 months. Of course, whether it was good or not, that decision should be made by history. But in Japan, people had more concerns about vaccinations, more skeptical when nobody in Japan had been vaccinated, whether this is good for us or not. That was a question raised. But there are Asians in the United States, and they were administered these vaccinations in clinical trials. So certain level of safety has been recognized. So we should accept this vaccine based on the U.S. data. I think that argument can also be made. It's a difficult decision at the government level, but with overseas approval, people who want the vaccinations can get administered. And once again, safety can be checked once again in Japan and can be administered to other people. So if that option was taken, then elderly people and people with existing underlying diseases, they know their risk, so they want to get vaccinated early on. I'm sure there is a group of people who want to get vaccinated early. So specified special approval process can be granted.
Regarding that point, for instance, low dose exposure in the case of Fukushima accident, I think there is a kind of a common thread in what you have just described. Yes, you think that the risk is low, but it's not zero. How do you address that in the case of contingency? So there's a clash of safety and assurance. Who should make that decision? It can be difficult. This may be addressed in the conclusion, but risk-benefit, weighing risks and benefits. Does the government do everything, and until the government guarantees, do people have to wait? Or, as a mature adult, people can make a decision, and then they make decisions, and then they have to actually take their own risks. As a mature adult country, that's one way it should be. I think you raised a very important issue. Thank you so much. We received several questions about testing. We would like to now talk about this testing. Dr. Takenaka, in your books, 4 capacity was raised. Testing capacity. Since the first wave, I think this has been a major problem, as you pointed out in the book. The number of tests here in Japan compared with overseas, is this really low? How should we take that? Any comment? There was only 300. Shiozaki-san, you mentioned that. But in administering tests, the capacity is low. That's why mass-scale tests cannot be conducted. May I share the screen? Please go ahead. Please take a look at it. Number of tests. The countries that have about the same number of deaths, Singapore, Australia, New Zealand. These are the comparable countries in terms of number of deaths. When the number of deaths is high, then the test number tend to be high. Just, if you look at these comparable countries, Singapore and Australia and New Zealand, number of tests overwhelmingly large. And then now they are controlling the infection. It's been Australia, New Zealand. It's been reported here in Japan as well. Specificity issue and the MHLW has explained, and I understand that. But again, number of tests is low in Japan. That's my opinion. Together with the testing in the downtown metropolitan areas, bars and in Shimane, I wouldn't say that in such a not affected areas you should do the testing, but Tokyo and Three Walls and Setagaya, mass-scale tests perhaps should be done. Even if there's this issue of specificity, I think we can still make a contribution to controlling the infectious disease. In this Independent Investigation Commission's report, it's mentioned cluster measures against the cluster. It worked well in the beginning. So in a way, kind of position was taken. So we are doing okay in addressing the cluster. That means that we don't need more tests. I think that's in one of the background of our discussion on testing. Dr. Suzuki, I'm sorry that this sounds like a deliberate question, but MHLW, they couldn't say that their capacity is limited. Maybe that's why they have talked about this, not necessary to conduct tests. Then it sort of transpired into what we should do or not should do. Instead, I'm sorry, because of many things, so that yes, the capacity is low. We are trying to boost the capacity. If we had higher capacity, we could do many better things. If you had admitted that, then you could have discussed how to enhance testing capability or capacity. You could have had that. But in the very beginning, you said, MHW said, not necessary to conduct tests, whether tests are effective or not effective. Energy was spent on that kind of an argument, which was unfortunate, in my opinion. The very first measures against cluster, I think there was, you couldn't help it. You had certain resources, you wanted to utilize it, so that's okay, but you didn't have to be particular about that.
Dr. Suzuki, since you've been designated to answer, there are 2 basic facts that we have to know. PCR tests. I think it's a very important tool to determine diagnosis, and until June, there was a dire shortage of testing capacity in Japan. So who should be tested? We prioritized the people who would be tested. We had to. We acknowledge this. But The issue is July onwards, when you have more capacity. 100,000, hundreds of thousands is our capacity, but it's only a fraction of that capacity that tests are given. And you made a comparison to Singapore, Australia, and New Zealand. And those three are very large. In terms of, those are outliers. Japan is inside the regular band, but Australia and New Zealand are outliers. Their infection cases are very small, but still they have an overwhelming number of tests. They are outliers, so I don't think we should use them as our standard. And I don't think there is any Ministry of Health officials who feel that we don't have to have tests. But if you administer tests, that will be sufficient to reduce infection rates. There are such arguments. And I would say that you need a more balanced view because our resources are limited. If our final objective is to reduce infection, then what would be the best mix? What would be the best way to use our resources? I think we should be clear-eyed in thinking about that. So as you say, Professor Takenaga, Tokyo, where there is more cases, we have to have tests, including asymptomatic people. If there is one infectious person or an infection case, everybody around should be tested. But whether do we have to do that in Shimane? Maybe not so. So we need to prioritize. If you have a clear-eyed discussion, you'll be able to come up with a good idea of where tests are to be administered. I don't think there's not going to be that big of difference. But in June, yes, we did not have enough capacity.
Thank you very much. Ms. Hashimoto, the number of testings matters, but responding to the pandemic, what is right and what is not right? Amongst the Japanese people, there has been all sorts of different discussions and arguments. Utilizing social media, there were many debates ongoing, perhaps making comparison with the other countries, and information coming from abroad. There were used as the grounds. Looking at the government's risk communication process, during the Fukushima incident, social media was not utilized that skillfully. But how to utilize social media now? And also to communicate with the other countries. There are many participants from overseas attending, and there are many questions that are being received in English language. So they have keen interest. So communicating and sending message to outside of Japan, has there been any improvements ever since the Fukushima accident? Information to be provided to who should send the message to whom is something we need to sort out. First of all, government was government successful in sending a message to the Japanese people? And what about the other countries, be it New York or be it UK or in Germany and so forth? The top leaders were every day having press conferences, but Prime Minister Abe, when the state of emergency was declared, that was the first time when Prime Minister directly has spoken to the Japanese people. Of course, the key persons every day in certain cases need to continue to provide information and give explanation. The key person should take on the responsibility. As was mentioned during the experts meeting as well, key person needs to take on the responsibility, but in that respect, there's still difficulty there as compared to 10 years ago for the Fukushima accident. But this time, at the ministerial class and also at the Prime Minister's office, through social media, there has been messages being sent and information provided. But even more than that, some on voluntary basis, experts that have been sending the messages. And it appeared as if the experts were filling in the gap for the government. So responding to the risks and the communication had to be done. Of course, primarily government needs to be responsible, but there are different players. Well, risk communication could be done by all sorts of different people, and that I think is more important. Thank you.
In relation to Hashimoto-san's previous comment, Sheik-san, from overseas participant, I received a question. You mentioned the experts. Feeling difficulty in expressing experts' view. Kante, or Prime Minister's office, is too strong? Is that why? Or somehow candidate discussions are difficult to take place? There are some difficulties because there's a certain background that are contributing to that difficulty. Do you have any comments, Hashimoto-san or any other persons? Just one comment. Economic measures and measures to COVID, people talk about the balance, and now the economic measures take precedence. Looking at the government stance, there's a concern that experts' comments can be sort of exploited by the government. Maybe that's one of the reasons. To give you one example, end of last year, whether to issue the emergency status declaration, this emergency declaration or not. December 23rd, in the subcommittee, emergency state of declaration, perhaps we're not in the situation to do so, to impose restrictions on operating hours and a wide scope of operators. But last press conference by Prime Minister, that wide scope of businesses, that was not omitted. And Dr. Omi also said that it was not necessary to impose or declare the status of emergency. So Dr. Omi's name was quoted. So people are concerned about being quoted out of context, and that's one of the things that has been pointed out.
When we made examination for the first wave, when expert sends a message, there will be in the social media, the complaints and criticism will concentrate on the expert. There were certain intimidations being made in certain cases. That seems to be continuing. I hear often from the medical association, doctors as well, such risks are there. So inclusive of that, people with different capacity and different positions should speak freely based upon certain grounds to be more active in communicating and providing information to guarantee such freedom of speech. That is something necessary for the experts to be able to speak freely. In relation to this, there's a question from Takeuchi-san. So Dr. Suzuki, would you be able to respond? In your earlier comments, how to utilize the experts and to have them more active. The role of division between the decision maker and those who provide the ingredients and materials for decision. At the end of the first wave, from the experts, there has been a final report being given on the 29th of June, and they said, using the strong word of forward-leaning, paraphrasing this, meaning that they wanted the national government to be more proactive. So how to ensure transparency within the government and division of role to make the decision-making process clearer and easier to be understood by the public. Has there been any improvements, any reviews being made on this?
For one thing, forward-leaning. What was insinuated was perhaps after the expert meeting for quite a long time, Dr. Omi or other experts addressed questions in the Q&A session. And MHLW bureaucrats were there, but they said almost nothing. Epidemiological situation, what's the situation? Some questions were related to that. And based on which, what was the government trying to do, what the government should do? There might have been such questions. So going after that, the higher ranking officials participated in the meeting, trying to address those questions and positively trying to share with the people the government stance. Getting the comments from those papers, and now among the bureaucrats, I think there was a certain roles and division of labor. Thank you. I had a question from Amano-san. I think Dr. Suzuki or Professor Takenaka, if you have answers, would you like to take this? Now, there is a shortage of hospital beds or medical care. The COVID-19 is classified as the class 2 infectious disease. That's why they had to be hospitalized in certain hospitals. Maybe that's one of the reasons. If it should be classified as type 5 or category 5, perhaps it should be changed. The classification should be changed. Your comment, please.
In the classifications for the Infectious Disease Act, there are 5 classes. There is one benefit of having this COVID-19 to be as class 2. The testing and up until hospitalization, the patients do not have to pay out of the pocket. The government will cover the expenses. If you make it class 5, then it will be 30% for the middle income people. It will be out of the pocket. Then, about hospitalization, in case of class 2, without exception, do we need to have everyone to be hospitalized? It just says it is possible to have them being hospitalized. It is not a must. So if it is a younger generation, it is mild symptoms, he or she could go back home or stay at hotels. But in the future, classification should be made perhaps more flexible. To what extent the expense should be paid out of the pocket, and to separate from the persons who need to be hospitalized, you need to be more detailed. But right now, putting in the class 2, I don't think that would invite so much strain on the hospitals. I don't think so. We are running out of time. We are close at the end of the panel discussion. But lastly, I would like to ask all the panelists. This time, unfortunately, the second declaration of state of emergency had to be issued. So lessons have been learned through first wave, and to what extent have those lessons been reflected into the policy? And what about the next national crisis, the next pandemic? What are the lessons that we need to learn from this time? So I would like to ask the views of each panelist. So starting from Professor Takenaka, please.
Thank you. I have 2 comments. As I already said, public health centers system, how to review them? What about the personnel? How to boost personnel? When we start discussing budget, so during normal times, what do these people do? Those might be the questions, but we are talking about contingency. It's important to make sure that we have those people available. We simply have to convince people because we need them. That's how I feel. So should it be transferred to Tokyo metropolitan government, or is it going to be directly controlled by the national government? We should have a discussion and improve the system. Another thing about type 2 or type 5 infectious disease, I think that the law was amended. We need to utilize those facilities for recuperating people, because if it's people asked to stay home, then other family members get infected and then it spreads. At the moment, most people just choose to stay at home for recuperation because it's convenient. And according to the public health centers, some people say that this is quarantine. Maybe this is something related to what people did concerning Hansen's disease. But public health centers, perhaps quarantine, isolation is now has a political hue, but recuperating those facilities, it's not a violation of people's rights. To protect the rights of the people who are not yet infected. That aspect needs to be emphasized so that people can respond to that request. And again, you might have this question that these people do during normal times, what do they do? But again, we need to have a system to ensure that.
Thank you. Turning to Hashimoto-san. There are many things that I want to say, but let me summarize them into 3 points. First, risk communication. Most recently, as I said earlier, vaccination, the issue of vaccination. Going forward, elderly people will be getting shots. Then a certain portion of them will have adverse effects. And after vaccination, some may end up dying. But it could be the day after, sometimes, in terms of probability. But whether cause and effect, you have to make sure that there was a cause and effect relationship. You need to explain this fully. It's not about risk. This is a correct understanding of the facts with respect to vaccines. So risk communication is important. Second point. Measures that people feel comfortable with, and it shouldn't waver. When you're stepping on the brakes, at the same time stepping on the accelerator, why are you putting into place these measures? There has to be transparency, and people have to be convinced. Number 3, planning is not just plans. You need to implement plans. I talked about the plan to secure enough number of beds. So who does what, where? You have to have those implementation plan. Vaccines will also be involved here. In the vaccination hall, who comes? What is the logistics? Who gets vaccinated? This is a lot of work, but you need to really put that into the plan all the way to implementation. These are the immediate challenges, important challenges.
Thank you very much. Then, Dr. Suzuki. There are 2 points. Firstly, at the time of emergency, we need to think about how to respond. We have to have a proper established system. Ever since the local, devolution had the law been established, local governments to be at the helm on the first-line defense. It is like the night security, a night guard, the state. For pandemic, the national government needs to be at the helm. We need to have an integrated system for command and control. And preparing for the emergency, the contingency needs to be put in place. There are uncertainties, but you need to make the decisions. You need to minimize the uncertainties as much as possible. As was mentioned earlier, you need to have the reserve, the people for the healthcare workers, and the PPE, the personal protection, the gear. You can have stockpiling, or to secure enough countries from where we can import, and we could have subsidizing the process in place. Even though the export could be suspended for 2 or 3 months, we need to have a system whereby we will still be able to utilize the PPEs. Thank you very much. As I listen to all your comments, as Professor Takenaka has mentioned, for the government, the municipalities, the governance system need to be made functional at the time of the emergency.
And as Ms. Hashimoto said, a coherent message from the government has to be communicated. That communication is important. And Dr. Suzuki, you talked about the fact that we cannot aim at having zero risk So a certain level of risk, how can that be understood and accepted by the community? And based on that, how can we make our progress forward? Those are some of the points that were impressed upon me. Now, because of time constraints, we can touch upon another topic, which is digitalization, using technologies. With the budget constraints and difficulty in making preparations, how can we overcome these problems by making use of digital technology? That's another important issue. As I said in my keynote address, a certain bureaucrat was saying that danger past, God forgotten. So on COVID-19, this is right. We're right in the midst of this danger. The heat is still on us. So when we still have feelings for the heat, how can we come up with the countermeasures is very, very important. We received many questions, but because of time, we weren't able to answer all of them. But we read your questions, including the panelists. That was very, very informative. And I would like to thank you for your participation. Thank you.